The goal of Journey 2 AKS Active Knee Solutions is to enable a higher level of function for total knee replacement patients to not only relieve pain, but to help them regain their active lifestyles. Unmatched function, motion, and durability is achieved through the unique features of the Journey 2 BCS system: anatomic alignment, kinematics, and advanced bearings. Patient outcomes can be directly related to accurate surgical technique and precision instrumentation. The Journey 2 BCS instrumentation has been developed to assist surgeons in obtaining accurate and reproducible results and reducing OR time. While it has been the designer's objective to develop accurate, easy-to-use instrumentation, each surgeon must evaluate the appropriateness of the following technique based on his or her medical training, experience, and patient evaluation. Attach the selected valgus angle bushing 5, 6, or 7 degrees to the valgus alignment guide. Check the bushing position to make sure that left is facing anteriorly when operating on a left knee and right is facing anteriorly when operating on a right knee. Attach a modular T-handle to the IM rod and insert through the alignment assembly. Assemble the distal femoral cutting block onto the valgus alignment guide. Positioning the block at the primary resection level will ensure the cut will equal the distal thickness of the femoral prosthesis. Lock by pressing the lever in a horizontal position toward the medial side. Open the femoral canal with a 9.5 mm intramedullary drill. Slide the intramedullary rod of the assembly into the femoral canal until the alignment guide contacts the distal femur. Orient rotation of the assembly neutral to the posterior condyles and impact one or both of the floating spikes into the distal femur. Using 65 mm non-headed speed pins, pin the distal femoral cutting block to the anterior femur using the holes marked 0. Once adequate distal femoral resection is noted, an additional headed or non-headed speed pin should be placed obliquely to provide additional stability. Unlock the lever on the valgus alignment guide, remove the intramedullary rod and the valgus alignment assembly using the universal extractor. Only the distal femoral cutting block should remain on the femur. Resect the distal femur, then remove the distal femoral cutting block. Insert the ankle clamp into the distal end of the alignment tube and thread the locking pin into the ankle clamp. After the ankle clamp is moved into the proper position, lock into place with the gold knob. Choose the correct left or right tibial cutting block. Place the appropriate left or right tibial cutting block on top of the disc on the non-spiked fixation rod. Tighten the central knob to lock the block into position. Introduce the rod into the extramedullary assembly and adjust and lock the cam in the assembly. Place the extramedullary tibial ankle clamp around the patient's ankle and align the extramedullary tibial alignment guide parallel to the tibial axis in the coronal and sagittal planes. Adjust the distal medial lateral slide directly over the middle of the tibio-talar joint, which is also approximated by the second ray of the foot proximal to the malleoli. The cutting block on the proximal end of the assembly should be proximal to the tibial tubercle. Assess rotation of the alignment guide and slope of the cutting plane. The goal is to align the extramedullary alignment assembly rotationally so that it aligns over the medial third of the tibial tubercle and over the second toe. Rotational alignment is critical due to the 3-degree posterior sloped cut. The slope can be adjusted according to the patient's anatomy. A neutral or slightly sloped alignment should usually be chosen. Attach the tibial stylus to the tibial cutting block by inserting the stylus foot into the cutting slot. Lower the cutting block until the stylus touches the low point on the least affected side of the tibia. The stylus can be adjusted for a 1 to 13 mm tibial resection by twisting the knob on top of the stylus. If the affected side of the tibia is to be used as a reference, the stylus may be adjusted for a 1 to 9 mm resection level. Pin the tibial cutting block to the tibia by inserting pins, first through the central holes, then the oblique hole. Insert the ankle clamp into the distal end of the alignment tube and thread the locking pin into the ankle clamp. After the ankle clamp is moved into the proper position, lock into place with the gold knob. Choose the correct left or right tibial cutting block. Place the spiked fixation rod through the hole in the tibial cutting guide. Adjust the block and tighten the central knob to lock the block into position. Introduce the spiked fixation rod into the proximal end of the alignment assembly and adjust and lock the cam on the assembly. Place the arms of the extramedullary alignment clamp around the ankle and adjust the distal medial lateral slide directly over the middle of the tibial talar joint, which is also approximated by the second ray of the foot proximal to the malleoli. The cutting block on the proximal end of the assembly should be proximal to the tibial tubercle. Impact the longer spike of the spiked fixation rod into the proximal tibia. Assess rotation of the alignment guide and slope of the cutting plane. The goal is to align the extramedullary alignment assembly rotationally so that it aligns over the medial third of the tibial tubercle and over the second toe. Rotational alignment is critical due to the 3-degree posterior sloped cut. The slope can be adjusted according to the patient's anatomy. Impact the second spike to secure the assembly. Attach the tibial stylus to the tibial cutting block by inserting the stylus foot into the cutting slot. Lower the cutting block until the stylus touches the low point on the least affected side of the tibia. The stylus can be adjusted for a 1 to 13 mm tibial resection by twisting the knob on top of the stylus. If the affected side of the tibia is to be used as a reference, the stylus may be adjusted for a 1 to 9 mm resection level. Pin the tibial cutting block to the tibia by inserting pins, first through the central holes, then the oblique hole. For the assembly with spiked rod, release the cam at the top of the alignment tube and use the slap hammer to remove the spiked fixation rod after loosening the thumb screw. The assembly with the non-spiked rod may be left in place or removed by loosening the thumb screw and lowering the non-spiked rod to disengage from the tibial cutting block. Cut the tibia by first directing the blade into the posterior direction and then laterally. Check alignment and balance with spacer block and rod. Balance ligaments in standard fashion. Insert the external rod of the intramedullary tibial alignment guide through the hole on the correct left or right tibial cutting block and lock the cam. Attach the T-handle to the IM rod and pass it through the cannulated alignment sleeve on the alignment assembly. Make a 9.5 mm pilot hole into the tibial canal. A preliminary resection of the tibial spine may facilitate seating of the tibial drill guide onto the proximal tibia. Slowly insert the IM rod into the tibial canal. Assess rotation of the intramedullary tibial alignment guide. Rotational alignment is critical due to the 3-degree posterior sloped cut. The alignment rod of the intramedullary tibial alignment assembly should align with the medial third of the tibial tubercle. Impact the proximal end of the cannulated alignment sleeve to drive the distal spikes into the proximal tibia to lock rotational alignment. Attach the tibial stylus to the tibial cutting block by inserting the stylus foot into the cutting slot. Lower the cutting block until the stylus touches the low point on the least affected side of the tibia. Pin the tibial cutting block to the tibia by inserting pins first through the 0 holes, then the oblique hole. To remove the assembly, use the universal extractor, leaving the cutting block on the anterior tibia after loosening the thumb screw. Cut the tibia by first directing the blade in the posterior direction and then laterally. Check alignment and balance with spacer block and rod. Balance ligaments in standard fashion. Assess the extension gap prior to making the posterior cut, as removing the posterior condyles can relax the posterior tissue and create a false sense of increased extension laxity. Assemble the quick connect handle to the appropriate size flexion extension block, available in standard and large. Attach the 10 mm flexion extension spacer onto the flexion extension block. If the extension gap is too tight for a 10 mm spacer and the distal resection is through the deepest portion of the trochlear groove, resect additional tibia. Assemble the quick connect handle to the appropriate size tibial spacer block, available in narrow and wide. Attach the 10 mm flexion extension spacer onto the tibial spacer block, as was done in the extension assessment. With the knee flexed to 90 degrees, place the tibial spacer block into the joint space, allowing the flat plate to reference off of the cut tibial surface and the stepped articular side to reference the native posterior femoral condyles. Apply a varus valgus force and assess the medial and lateral compartment laxity levels of the flexion space. Then adjust thickness of spacer as needed to determine the flexion space. When the flexion space is determined, compare the thickness selected relative to the extension space. Place the left or right Journey to DCF sizing guide on the resected distal femur, with the medial paddle mated to the posterior medial condyle and the sizing guide flush to the distal resection. Place a 45 mm headed speed pin through the hole just above the medial paddle. This will secure the sizing guide for the remainder of its use. If there exists a known flexion extension imbalance, unlock, translate, and relock the drill guide appropriately. Ensure that the lateral paddle is mated to the posterior lateral condyle. Begin with the paddle set to 3 degrees. Rotate away from 3 degrees if it is desirable to match the AP or epicondylar axis, or if it is desirable to balance the medial and lateral flexion gaps. Once both the AP and rotational measures are desirable relative to the anatomic landmarks, drill about a 1-inch or 25 mm deep hole through each of the 2 holes in the drill guide. Finally, assemble the journey sizing stylus to the guide and estimate the AP femoral size. Position the stylus tip just lateral of the anterior trochlear sulcus. The Journey to DCF sizing guide is designed to reference the posterior condyles. At 3 degrees, the guide will make AP resections at 3 degrees externally rotated from the posterior condylar axis. The guide also allows for rotation between 0 and 6 degrees relative to the posterior condylar axis. Position the spikes on the DCF AP femoral block into the pre-drilled holes. Use the mallet to impact the AP block assembly until the block is flush with the resected distal femur. Remove the AP block impactor. Note that the posterior resection will match the implant thickness when the highlighted indicator in the AP block knob is aligned with post-ref. Use the angel wing to check the location of the anterior cutting slot. Make any necessary anterior-posterior adjustments to avoid overstuffing the patella femoral joint, overstuffing the flexion space, or femoral notching. Complete the cuts in the order indicated on the block. Assemble the quick connect handle to the appropriate size flexion extension block. Attach the 10 mm flexion extension spacer into the flexion extension block. The flexion extension block with 10 mm spacer should easily insert into the flexion gap. Use the 10 mm spacer as a gauge to ensure a minimum of 1 mm of flexion laxity. If the 10 mm spacer block goes in tight in flexion and loose in extension, consider downsizing the femur. If the 10 mm spacer block goes in tight in flexion and extension, consider taking 2 mm more tibia. Adjust thickness of spacer as needed to determine the flexion space. The recommended time to prepare the patella is after all tibial and femoral cuts are made, but prior to trial placement. Attach the patella reamer guide to the patella and tighten the reamer guide on the patella. Use the patella calipers to measure the patella thickness through the collet and guide. Attach the patella reamer shaft assembly to the drill and lower the reamer through the patellar reamer guide until the reamer dome contacts the patella. Lower the patellar depth stop until it contacts the patellar depth gauge. If the biconvex design is selected, use a towel clip to insert the appropriate diameter biconvex patella trowel into the recess in the patella. If the resurfacing design is selected, use the patella caliper to reassess the patella thickness. Select the appropriate diameter resurfacing patella drill guide and slide it onto the patella reamer guide. Attach the patella reamer guide assembly to the reamed patella and tighten the reamer guide on the patella. Select the baseplate trial based upon best fit and coverage on the resected tibia. Set position of the tibial baseplate based upon the anatomic landmarks of the tibia, best fit and coverage and medial third of the tubercle. Place the femoral trial onto the femur by positioning the proximal edge of the posterior condyles at the proximal end of the posterior resection. Impact on the angled surface of the femoral trial impactor to rotate the femoral trial from posterior to anterior until the distal surface is completely flush with the distal resection. Insert the appropriate size Journey 2 BCS collet into the T-slot of the femoral trial from the anterior side until the pegs on the collet engage in the femoral trial. Insert the reamer into the BCS collet and ream first anteriorly and then posteriorly. If the power equipment has drill and reamer settings, ensure that the drill setting is selected and allow the reamer to reach maximum speed before engaging the bone. Insert the chisel into the anterior chisel guide. Impact the chisel through the guide until flush with the collet. Repeat punching using posterior guide. Remove the BCS collet by lifting up on the outside casing to disengage the pegs and sliding anteriorly. Position the anterior tabs of the Journey 2 BCS box trial into the femoral trial's anterior recess and rotate the box trial posteriorly until the femoral trial detents have secured the box trial. Use the angled face on the femoral trial as the guide, remove the anterior intercondylar femoral bone using a narrow saw blade. Select the appropriate size Journey 2 CR notch trowel and engage the anterior portion of the notch trowel first. Then use the femoral implant impactor to impact the posterior portion of the notch trowel until it sits flush with the femoral trowel. Use the lug drill to prepare for the femoral lugs by drilling to the bottom of both distal holes in the femoral trowel. Placing the insert trowel into the trowel baseplate can be difficult because of the high medial posterior lip of the insert. The best technique is to flex the knee to 120 degrees, push in the insert as far as possible, and bring the leg out into full extension. Perform trial range of motion and assess laxity and balance. The knee should drop passively into full extension. Under varus valgus stress, there should be approximately 1 to 2 millimeters of gapping, both medially and laterally, throughout the range of motion. Once the trial assessment is completed and the correct insert thickness has been determined, then take the leg into full extension and use a cautery to mark the location of the laser etch lines on the anterior cortex of the tibia to reference the baseplate rotation. Once the trial assessment is complete and final implant sites determined, remove the insert trial and femoral trial. Fin punch through the baseplate with the appropriate size punch. Remove the 2 short speed pins with the speed pin driver and remove the baseplate trial. Maximally flex the knee and place a thin bent homen laterally and medially and an off-rank retractor posteriorly to sublux the tibia forward. Use the tibial implant impactor and mallet to fully seat the tibial baseplate component onto the proximal tibia. Remove excess cement. Assemble the femoral implant impact bumper available in left and right onto the femoral implant impactor. Press the thumb lever on the posterior side on the femoral implant impactor and push the dual arm mechanism upwards. Position the taller arm inside the posterior cam of the femoral component and rotate the shorter arm onto the anterior cam. Release the thumb lever. Flex the knee, keeping the thin bent homen laterally and removing the off-rank retractor. Place the femoral component onto the femur by positioning the proximal edge of the posterior condyles at the proximal end of the posterior resection. Impact on the angled surface of the femoral implant impactor to rotate the femoral component from posterior to anterior until the distal surface is completely flush with the distal resection. Extend the knee to remove cement anteriorly without retracting the proximal soft tissue. Assemble the femoral implant impactor bumper available in left and right onto the femoral implant impactor. Unlock the knob completely. Press the thumb slide on the femoral implant impactor to push the dual arm mechanism upwards. Position the arms inside the intercondylar notch of the femoral component and release the thumb slide. Make sure the tips of the arms are sitting flush in the crescent-shaped grooves on the femoral component. Lock the knob until hand tight. Flex the knee, keeping the thin bent homen laterally and removing the off-rank retractor. Place the femoral component onto the femur by positioning the proximal edge of the posterior condyles at the distal end of the posterior resection and rotating the femoral component to align the tips of the lugs to the prepared lug holes in the femur. Impact the femoral implant impactor until the distal surface is completely flush with the distal resection. Clear any debris from the locking mechanism. Manually slide the insert into the tibial baseplate, engaging the locking mechanism until the insert periphery is within 1 to 2 millimeters of the tibial component periphery. Insert the tip of the articular insert assembly tool into the center notch of the anterior lock detail, handle up, and engage the two tabs of the tool into the two recesses on the anterior periphery of the insert. Squeeze the tool handle until the insert is fully seated within the tibial component. The insert should not move under any pressure in flexion or extension. Close the arthrotomy by placing 3 ovicral sutures at the superior border of the patella, just distal to the VMO. A stitch is placed to close the VMO fascia. The remainder of the arthrotomy is closed in the standard fashion. Radiographic note: the Journey 2 bicruciate knee system features an anatomical joint line in the AP view. The distal condyles of the femoral component will present a 3-degree varus angle relative to the tibial component when correctly aligned.